Thanks for joining us.
You're very welcome.
We had to call you back. I think last time you waited around for us. So we apologize.
No worries. I understand how this works. How do I pull up on this screen here the slides?
Just tap.
Just tap on.
the blue icon.
Oh, outstanding. Okay. Good afternoon, everyone. I'm Brian Murphy. I'm the Director of Pharmacy and Vendor Management at Blue Cross Blue Shield of Vermont. We provide a pharmacy benefit for about 140,000 Vermonters. Our big clients be the Teachers Union, VHI, University of Vermont, the Exchange, obviously about 40,000 Exchange members. So what I'm going to walk through today, kind of talk about drug trends on the pharmacy benefit, but I also included in here part of the presentation on drug trends on the medical benefit, because we never really talked about that. A lot of times I've come by in the past, we've talked about, the pharmacy and the mechanics of how pharmacy benefits work and the cash flows and everything, but we never really got into the medical side of it. So I have some slides in there too, because people don't realize half of all the specialty drug spend that we have occurs on the medical side. So we all know that specialty drugs has been a big driver of the trend, but we don't ever really look at the other half of it that's on the medical side. So some slides in there too.
Maybe you can explain what you mean between pharmacy benefit and medical benefit.
Thank you very much. Good point. So when I say pharmacy benefit, what I mean is that's the part where a doctor writes a script and you go to the local pharmacy and you show your ID card and the pharmacist fills the script off the shelf and you take it home. That all flows through the process we talked in the past with the pharmacy benefit manager and so forth. That's what people often think of as your pharmacy benefit, right? The parts going through the medical benefit, what I'm referring to there is the drugs that get infused in the hospital, typically, or a doctor's office and so forth. So this would be oncology medications, infusions to treat rheumatoid arthritis. This would include home infusions even and so forth. So all of that comes through in a different mechanism. That doesn't go through the pharmacy benefit manager at all. Those claims come directly to Blue Cross Blue Shield. So we are, work with the hospitals that set the reimbursement rates on those and everything. So that's the distinction between the two. Does that make sense for everyone? Okay.
And just so everyone knows, I did chat with Brian before we started, and he's okay with taking questions as we go. We'll just make sure we get through the
Right. In the past, I think I've gone through about 3 of my slides. I'm hoping to set my record and break it and get to 4 slides. So
we'll try and do our best.
Yeah.
Let's start until the 4th slide.
Yeah, excellent. So, all right. So let's start out talking about the pharmacy benefit. This is once again what's going through the pharmacy benefit and so forth, and just give you a sense of what we're experiencing, our members are experiencing in drug trends. So if you look at the numbers broken out from 2013 to 2019, this is through 3 quarters of the year. So I didn't have the full years at that time when I was putting this together, but through 3 quarters, what we're projecting to have for the full year 2019. And you can see that's grown from $64.09 in 2013. It's grown to where now it's $101.30 just a few years later. So that's been a pretty significant growth during that time period. And you can see the year-over-year trend. It generally has been running somewhere around the 7 to 10% range. The one anomaly to that trend rate is the 2014 trend, which was 1.5%. The only reason that was lower, if you remember, that was the first year of the exchange, and there's a hiccups with the website, that people were having trouble accessing the website. That wound up actually, people didn't access their benefits, so they wound up using less, so that wound up causing a smaller trend. So that's an artificially low trend. If that trend had been, if that website hiccup hadn't occurred, we probably would have had trend similar to the other years and so forth. Does that make sense? So you can see we're having some pretty significant growth. This is one of the highest growth rates in anything in healthcare, right? So hospital isn't growing this fast, physician office visits, everything. This is one of the biggest drivers. Overall, pharmacy cost is about 18 to 20% of overall costs of just the pharmacy benefit. So having that big of a chunk grow at these rates is challenging for everybody. Right? So the question is, why is this growing? And when we look at drugs, the way we often split them out is between what are called specialty drugs and non-specialty drugs. Non-specialty drugs are your traditional pills and capsules, Lipitor, Prilosec. These are things that are very common and so forth. And then specialty drugs, which are used by very few people, usually around 1 to maybe 2% of the population. They treat rare conditions. They're often injectables. They require some extra special care and handling and so forth. So what has been going on in the distinction between these two, when you break it out, if you look at the trend on non-specialty drugs, it's actually gone down somewhat. That's where we see most of our generic drug use. And we've been doing a really good job of encouraging the use of generics, which has a much lower trend rate in terms of growth in the unit cost, the cost per script. And you can see from that, there's been pretty flat growth. If anything, it's down a little bit, and that's worked out well. It's that growth rate on the specialty, where specialty has gone from $19.05 in 2013 to where it's now, for 2019, it was 50, it's almost $60. It's almost basically tripled in that same time frame. So you can really see that's what's really driving the trend rates that we're looking at here, right? It's really the factor of, at this point now, we're spending about 55% of all of our pharmacy costs are on specialty drugs, okay? So now the question is, what's driving the specialty drug trends, okay? So,
Can I ask you a
yeah,
question?
sure.
Specialty drugs, pills for cancer, specialty drugs.
That would be specialty drug, correct. That would fall in the case of, like Gleevec is, a treatment for leukemia. It's a specialty drug, even though it's not injectable and so forth. But you want the person to have a little extra care and management around that, so we have nurses reach out to them and so forth. So that does fall in the category of specialty drugs. That's correct.
And how about insulin?
Insulin falls into the non-specialty. So I don't have slides on insulin. If you have questions about insulin, I'd be happy to talk about it. But that falls into the non-specialty, which is actually next month. This is a little fun factoid. The FDA is going to reclassify it. It's going to get moved over into the biologic category, which is another word for specialty. By doing that, it'll finally create a legal pathway for the development of a generic or biosimilar version of it. We had never had that before. Insulin was developed in like 1922, and so it actually predated the FDA and the approval process and so forth, so it got grandfathered in as what we call a non-specialty drug. So by going ahead and reclassifying that, they're creating a legal pathway for the development of that. It doesn't mean like in April we're going to have that, but Mylan and Merck are both working on the development and the approval of those. So, yeah.
Isn't California looking at the possibility of making their own insulin?
Yep. So California is looking to do a similar venture to what we, Blue Cross Blue Shield, just worked on. I don't know if you saw the press release around Civica. So we're going to go into the drug making business. I got a little bathtub out back. We're going to swirl up some stuff. I joke about it, but seriously, it is going to be all done in a very serious manner. And we have a list of drugs that we're going to start with, and then another list of drugs in the second wave, and so forth. And California's looking to do the same sort of thing. Now, we've talked about insulin on that. To develop a facility to make insulin would cost about $1 billion, right? So our initial investment in this endeavor is about $55 million. That's all the Blues system together. So we're well short of that $1 billion needed. California would probably come up short on that too. Everyone wants to be able to do that, but the financial realities are really tough. The more likely scenario is to perhaps do some sort of a huge bulk purchase of insulin from Novo Nordisk or Eli Lilly or one of the other large manufacturers, and try and do something like that to try and bring the price down. But the longer term expectation is that we'll start seeing some competition as a result of this reclassification and the approval process now in place for generic / biosimilar version of insulin. So.
And just for the committee, a couple years ago, we passed legislation that focused on biosimilars to ensure there was a pathway once they started coming to market.
So what that did was, there's been a law in the books for a long time about generic substitution, so that when a generic drug came out and the FDA rated as interchangeable and so forth, and it got approved by the FDA, that the pharmacist would be able to make that automatic substitution right there at the pharmacy. And then you guys added on to that the biosimilars, so that as biosimilars come to the market, they'll be automatically substituted too. So that was very helpful. All right. So,
I have a question. When you were talking about, one possibility in the future is to buy bulk, and would that be Blue Cross buying bulk? So if I had MVP and I went for insulin, it would be a different price than bulk? We're talking about theoretical because you haven't done this yet. But is that what that means?
So
you would have way better.
What I was referring to was through that Civica venture where we're talking about manufacturing own drugs. The aberration to that would be with insulin, where rather than spending $1 billion to develop our own facility, would be to go ahead and short term try and buy in bulk through that effort. Now, that effort was really started by the Blue Cross Blue Shield plan, but other health plans are allowed to buy into that venture. The folks at Civica are very mission driven, and we're really happy that Blue Cross is bringing this, but this needs to be a nationwide solution, not just a Blues plan solution. So other health plans have been, talking to Civica about joining in on this venture. So whether it's MVP or Cigna or anybody else joins in on it, that's a possibility. But at this time, MVP is not a part of it. But they may join at some point, I'm not sure. That'd be more of a question for Susan.
So you could have this wide variable in pricing on insulin if such a thing came about?
So you start getting through the market economics of it. If we were to bring it in at a lower price, there's a good chance that the manufacturer would wind up start competing and lowering their price too. Or if they don't, then there would be a large price differential. So we'll see what winds up happening. But it starts playing out into market dynamics and so forth. So
Okay,
what to
thank
say.
you.
All right. So the inflation rates. So right here I have the inflation rates broken out between generic drugs and brand drugs. The majority of money flowing through on the brand side is specialty drugs. So that when you see the red column, that's really a proxy for specialty drugs. And this is the price increase on average that manufacturers took on the list price, the AWP, the average wholesale price on brand drugs. And versus the blue is generic drugs. So you can see, remember I was talking about, we've done a really nice job of encouraging use of generics. So you can see the much lower growth rate on that side. That has worked really well. It's on the specialty drug side where those large price increases have occurred. Now, if you take a look at it, you do see that those price increases have been coming down, and we're happy about that. Now, that has been helpful. Here's the flip side to it, is that at the same time that, if you look at those two graphs back to back, you notice where as the price increases started to come down, utilization started ramping up. And that's where one offset the other, and that's how we have a continuous growth in specialty drugs costs during that entire 7-year time period. Okay, so the reason why drug trend is occurring, especially drugs, and the reason why specialty drugs are trending so high is a combination of two things. In earlier years, high price increases. Those price increases are come down somewhat, but at the same time, inflation or increasing utilization has overtaken the other part of it to offset that and keep the costs keep on moving on up. Does that make sense? Always worry that I go over these things too quickly. So a couple other points about this. Now, let's go back to the price increase. Humira and Enbrel are two of our largest specialty drugs, right? So let's drill down and look at their price increases. These are competing drugs. They both treat rheumatoid arthritis, which is, in the specialty drugs is fairly commonplace. These drugs are expensive. They're administered once a month. People do the injections at home with them. So these are two drugs that are supposed to be competing with each other. Check out the price increases year by year. It's an amazing coincidence that they have selected the same price increase year after year to be within a point of each other. So remember 2 weeks ago when Jill Abrams was here testifying about the bill, and we were kind of talking about the mechanics of having one formula to get to what it is that we want to ask about is tricky, right? MVP, Diva, and Blue Cross Roll come up with different drugs and so forth. It would be nice if we could work just with the Attorney General to say, here are issues that we've identified. It doesn't follow a specific formula. It's not exactly prescribed by the bill. But if I sat down with Jill and showed this to her and say, hey, could you go to the manufacturers, go to AbbVie and Amgen, and ask them, why is it that your price increases were identical or nearly identical year after year, right? Like in a competitive market that's functioning properly, why is that occurring, right? I would love to have an answer to that, right? So it boxes it in a little bit as to what they could possibly say. So if you're going back to the other one, if you're looking for ways to adjust it, I would like to be able to have some more, less prescriptive and a little bit more free-ranging on that. What should we ask?
We need to authorize that statutorily, is that correct? I mean, with the way we have it written in the stat, or
Right.
maybe I direct that to Ledge Council, maybe just say, I'd like to make sure I understand what we need to do and make sure that the recommended change is possible.
Yeah, so, all right. So but this gives you a sense of what has been going on in the specialty drug pricing market. With regards to the increasing utilization, so Humira is manufactured by a company called AbbVie, and this is their advertising in TV. Remember when we started seeing the utilization really spike up? This is the direct-to-consumer advertising on TV that AbbVie has put into Humira. It's grown by 36% from 2014 up to 2018, to the point where we're talking about almost $500 million is spent on advertising Humira to folks every single year. So just to give you a sense of what's possibly driving a lot of that utilization. Now, we have prior authorizations on everything to make sure there's not inappropriate utilization. So I'm not implying that there's inappropriate utilization, but they just make sure that anybody that would possibly think about this has talked to a doctor, and this is front in their mind when they go talk to their doctor. All right? Any questions about?
So you think the advertising is a direct relationship to increase utilization?
Well, it's-
Or is it because people have better, better full insurance or coverage or what?
So there has been the Federal Trade Commission changed the rules on direct-to-consumer advertising in the mid-90s. If you look at the rate of utilization of medications since then, it has grown significantly. Manufacturers continue to put a lot of money into TV, radio, magazine advertising. They're not doing it because they're a charity and they want to help out the TV stations. They're doing it because they find that there is a correlation and it does work.
Right.
So, yeah.
You just mentioned that there's been an increase in spending on advertising that is connected with an increase
In utilization.
in utilization. Is there any connection between that increase in utilization and health outcomes or population health?
So this is a good point, right? So the increase in utilization goes to go ahead and satisfy that there are people that are needing medications, right? So we do our best to make sure that it's used appropriately. So, but it does increase that, right? So it's two sides of it. That we are happy that these drugs are out there. We're happy that people are accessing those medications. The question is, how do we make this financially sustainable for everybody, right?
But is there any evidence that those medicines are actually working and making everyone who take them health better?
So Humira is a wonderful drug. You're living with rheumatoid arthritis. You're largely bedbound in a severe case and so forth. You start taking medication, you're up living a normal life. Like, there's not a question about the quality of the drugs. The question is about the pricing, right? And whether or not these price increases are necessary year after year, right? Humira actually lost its patent protection a few years ago, and they have been fighting in the courts of development and the approval of a biosimilar wholeheartedly. And we don't think we'll see a biosimilar into the market because of those lawsuits until the year 2023, right? So I'm not here saying that Humira is a bad drug, that people shouldn't be taking it. It's a wonderful drug. My point is that the costs are high, the costs are going up at a rate that's driving the overall trend and makes it difficult and unsustainable in many ways.
And you were talking about the inflationary rates for specialty drugs, which, as I remember, the inflationary rate actually was coming down, but the utilization was going up.
Correct.
I found myself wondering, is there any information you have or any distinction between newly introduced specialty drugs and how they are acting in the market?
I don't have that here, but I could go ahead and get that for you and just, send it back on over to Dennis and she could supply it to everybody. But yeah, we could look at that way. So, quite often the new entrants to the market are a little bit better and they wind up pricing it a little bit higher to offset for that. So, okay. All right, so continue on the idea about manufacturing and price increases. This is just a look at the net margin by year for pharmaceutical manufacturers, which is in the red column, and then specifically AbbVie, since we were talking about Humira and then their amount of advertising. You can see the amount of margin on average that they're making. It's quite often floating in that, say 15 to 25% range. If you think of most businesses in America, average somewhere around 7 to 8% margin. Is well outside the lines of what you would expect in a normal, competitive, healthy marketplace. Specifically, when you start looking at the industry margin, and I've shared this slide in the past, you think of, there's pharmacy benefit managers, like Express Scripts, CVS and so forth. There's pharmacies such as CVS and Walgreens, and then the manufacturers. And if you look at the margins, that bottom line, the net income line, 3.3% for the PBMs, 3.8% for Walgreens. That is indicative of very competitive markets where no one's able to take these outsized margins. But then if you look at Amgen specifically, the manufacturer of Enbrel, 30.7% margin in 2018. So it's so far beyond American business averages, the pharmaceutical industry averages. One part of this supply chain has an advantage over the other parts. We have intellectual property rights in this country that is allowing that to occur. Now they're using that to go ahead and make great medications, but they're also charging a high price and going ahead and taking large price increases to sustain those 30% margins. Right. And that ultimately winds up leading to driving that trend we saw in the first slide. Yep.
Just not having a background in financials.
Yeah.
So is the 30.7% before or after what gets invested into new development?
So net margin is after. So
Okay.
when you think of
So that's not
yep.
not including the money that they're investing in.
You're right. So when you think of gross margin, it's the sales minus the cost of the goods of those items
Yeah.
sold, right? So like
Yeah.
your raw materials and everything.
So that's the 63.9.
And then after that, you wind up with all your overhead. That's being your research development, your marketing efforts, your the buildings that you own and so forth. That gets it down to 30.7%.
Okay.
All right. So that gives you a sense of trends on the pharmacy side. And this is a part of that. I don't think we've ever really talked about the drugs on the medical side. So I wanted to take some time to kind of talk on that side. But before I move on over to that, any other questions about stuff on the pharmacy benefit? Yes.
At some point in time, and I think we might have, maybe we have something on the agenda today, but I feel like we need to have a much better understanding of what happens with pharmacy benefit managers.
Sure.
And maybe I'll just leave it there, but I remember after you did a presentation similar to this in the past, I was approached by someone who said, you really need to look at those numbers. 3.3% margin for pharmacy benefit managers does not begin to tell the story of what is happening for pharmacy benefit managers in terms of
The thing to remember with pharmacy benefit is a massive volume, right? So like Express Scripts, the company that we work with, I forget their exact numbers, but it's like $100 billion a year in revenue. So 3.3% of that is a really nice cut, right? Like it's still, in the end, you're dealing with really large dollars and everything. It's just such a huge industry that winds up being happening. And I'd be happy to come back. I had spoken about PBMs in the past, and I wanted to keep somewhat fresh to share some new information. That's why I wanted with these numbers.
Great.
But I'd be happy to come back and do a specific thing on just PBMs as well.
I think there are others who may be interested in this
Yeah.
as well.
Sure, be happy to. All right. So as I mentioned before, this is the part that I don't know if everyone always understands that when we talk about specialty drugs, we're often thinking about like Humira, Enbrel, and Copaxone, those treatments that are those home injectables and so forth. And you can see for Blue Cross Blue Shield of Vermont in the upper left-hand corner here, that's about $36.2 million a year. At the same time, though, we have about another $29.2 million that's going through the medical benefit. And that's a pretty significant chunk of money that we don't really ever talk about. And so the question is, where is that dollars occurring? And so I broke that out between physician offices, home infusion. Home infusion would be if a nurse comes to your house, does the infusion for you. It's not like you're going to the pharmacy and doing the injection yourself. This is an actual administered by a nurse. Hospital inpatient, which is a really small part of it. And then hospital outpatient. This is like where someone would go into UVMMC or Dartmouth-Hitchcock and getting a infusion done there to treat rheumatoid arthritis can be treated there with Remicade. There's often your oncology treatments and so forth. So that's where a big chunk of that is falling. So that's just specifically what we're talking about. Now here's the thing. In the blue is Blue Cross Blue Shield of Vermont's distribution on these costs in the different settings. And then in the red is the nationwide averages. As you can see, Blue Cross Blue Shield of Vermont spends more than double its portion of its costs on the hospital outpatient for specialty drugs as opposed to any other area compared to the national average, at 34% versus 16%. So we have a much higher expenditure in that area than others.
Are you going to talk about why?
Yeah.
Okay.
But wait, there's more.
I knew that was a question for someone.
Exactly. So here's some benchmarking about this. Just to give you a sense. Once again, when we're looking, there's a lot of numbers on this page, so just walk through it. What you see in this column, sorry about that, that's our actual. So when I say actual, that's Blue Cross Blue Shield's numbers. Okay. The next is the industry average. So that's industry averages gathered from we worked on this with an outside consultant, and so this comes out of their database and so forth. The next part is the variance, the delta between us and the industry average. Where it's in black, that means that we're higher, or we're basically higher in that area. Red would mean, I got that backwards, but it's a variance. So, and then on a percentage basis as to how big of a variance it is. Then the last two columns gives you the industry low and industry high. So it gives you a range as to how much is typical varies and so forth. So the percentage of specialty costs being on the medical side, you can see for us is at 55%, where the industry average is at 42%. So this kind of just follows on to the prior slide as well. And what proportion of that is occurring in the hospital outpatient setting on the medical side? We have 80% of that, where the industry average is 58%. So that kind of just solidifies the point I was making on the prior point. It's this line down here about outpatient hospital as a percentage of ASP. ASP is the average sales price. So when you're looking at the pricing of drugs on the medical side, average sales price is a metric that is used to say, all right, here's what the average is and what percentage of that average are you. So, Medicaid, I believe, is, Nancy, I believe Medicaid, you were saying, is like 97% of ASP, to give you a sense of where they come in at. Medicare, usually at 108% of ASP. And you see where we are. We're at 219% of Medicare, 219% of ASP. The industry average for that is 187%. If you look at the range, the industry range from this consultant's database, 154% on the low side to 217%. So we exceed even the high end of that. So we have an issue of us reimbursing hospitals a lot more than industry averages on these medications. So when we've always been talking about specialty drugs on the other side, there's this other side of it where we have a much similar story of really high pricing for those specialty drugs occurring in the hospital setting as well. Right? Yeah.
Can I ask two clarifying questions?
Sure.
Sorry, Mark. And then, so when you talk medical in the hospital, does this include if I'm in the hospital and I'm leaving and they give me a prescription to go home and I fill it at the pharmacy at the hospital? What would that fall under?
That pharmacy in the hospital is part of the pharmacy benefit network.
Okay, and then this might not relate at all, but are 340B cost drugs in here somewhere?
Yes. So the 340B drugs can occur on both the pharmacy benefit and the medical benefit.
Okay. Does everyone in the committee know what 340B is? Ryan,
So-
can you
Remind me.
take a minute?
Yep.
2 minutes?
Thank you.
How much time do I have?
Yeah, I know.
It's important to.
Yeah, so, all right, so 340B is almost a 30-year-old program started on the federal level to go ahead and help fund disenfranchised hospitals, if you will. Like, it really started out as a government program to go ahead and fund government hospitals, military hospitals, and so forth, where the idea was that when someone goes ahead and fills a script, the cost of the drug would be brought way down, and when they get reimbursed in this amount, it would create this artificially large margin that would go ahead and help fund the rest of the operations of the hospital. Okay, so manufacturers were participating in this by going ahead and lowering that price, right? Over the years, Congress has made numerous changes to that law to go ahead and expand what counts as a participating hospital for a 340B hospital. And it became FQHCs, the ones that have a very high share of Medicaid and Medicare patients became part of that, Native American hospitals and so forth. So they keep on expanding what hospitals this applies to. And then I think around 2010 or so, they expanded how they can go about having drugs count as a 340B. It used to be that it had to be filled at the hospital, whether through the outpatient pharmacy or through the hospital pharmacy. They changed it so you could contract with local pharmacies, so that local pharmacies, if it was a script written by it's like the 4 Ds of it, the local doctor, the doctor associated with the hospital, of certain drugs written on certain dates where that drug was a participating drug in the program, and dispensed at a participating pharmacy, that would count for 340B also. So if University of Vermont Medical Center contracts with hospital or pharmacy XYZ in Burlington, they can go ahead and a script is filled there written by a UVMMC doctor for a drug that's a participating part of the drug, on a day that drug was part of the program, they would go ahead and get these 340B dollars. So that outsized margin that is made, that goes back to the hospital to help fund the operations. So that has grown to a point where I don't know the exact portion, but it's a significant part of the funding that goes into hospitals. So as hospitals go ahead and administer more drugs and write prescription for more drugs, they get more of that 340B money coming into them. Does that help?
Are Vermont hospitals, how many of them are?
That would be a question for some of them. I think just about all of them. Critical access care hospitals, I think we're on that list, so almost all of the Vermont ones fall into that.
So the hospital benefits from the lower cost of the 340B
Correct.
drug. But the financial benefit of it doesn't go directly to the consumer.
With the exception of some of the FQHCs,
Well, I was just going to bring up
like Dr.
FQHCs, which are not
Matthew,
hospitals.
right, exactly. Like Dr. Matthew does a wonderful job of, he takes a portion of that and passes it along to people in need of that, right? So he'll lower the cost of drugs for those folks in those situations. So, I'm sorry, Plainfield Health Center. I'm sorry.
Okay, sorry.
Yeah, I'm sorry.
Who we're talking about.
Yeah, no, Dr. John Matthew, he was really, if you've never been out to Plainfield Health Center, I'd recommend it. It's a really amazing facility that he created and runs out there. And, a lot of it is funded through 340B and, the FQHC dollars that are available. But he is one where he does take a portion of that to lower the cost for the people.
But they also have a community health pharmacy.
Right.
If you're a patient through an FQHC, well, I don't know if it's all the FQHCs, but through many of the FQHCs, I believe,
Yep.
in Vermont, you can actually access your pharmaceuticals through the community health pharmacy, which is owned, but it's operated by the
Correct.
FQHC, so that you actually get a lower cost.
Right, because they've made a choice to go ahead and pass that
Right,
cost
that's what I'm
along,
saying,
as
yeah.
opposed to just
That's-
using it all for funding the operations.
Yes, that's what I was making that distinction.
Exactly.
So understanding 340B, it's important to know that both things are happening.
Yep, exactly. So that's the exception to the point, yes.
Thanks for waiting, Rick.
Yeah. Back to the outpatient hospital percentage of ASP, and Blue Cross reimbursement rate is at 219% of the ASP.
Correct.
Why?
So,
Yeah, okay, I'll just let you.
yeah. This is a tricky one, right? We don't have enough leverage to just dictate and say, oh, well, we're going to go ahead and reimburse you 108%. You're going to have to really like it, right? We have to reach an agreement with them. They go about having their budgets set by the Green Mountain Care Board, right? And so they come back and they say, well, the budget was set at this number of dollars. We know Medicaid is going to be reimbursing at this amount. Medicare is going to be reimbursing at this amount. That leaves this amount that has to be covered by the commercial private payers. And when you do the math on that, it winds up coming in at this much higher rate, right? And so we try and push back on it as much as possible, but some of this is, we have to keep our hospitals running, right? They need to have that funding and so forth, but we have to trust in the Green Mountain Care Board is going to keep that budget as tight as possible so we can go ahead and lower this as much as possible, right? You also need to get into the mechanics of a rural area, right? We don't have that many people to spread all these costs over, and if a high portion of them are coming at 97% of ASP and 108% of ASP, that leaves a lot of money for a smaller part of the population to go ahead and cover the cost of the operations of the hospitals, right? And so we wind up with this outsized cost on this. So,
Thank you.
So, do we know whether hospitals are abusing this system in order to create more funds for their particular hospital?
I'm not an expert in hospital funding, so I would be out over my skis on that one.
And I guess you did say the Green Mountain Care Board controls this? or
They
oversees
set
it?
the overall budget for the hospital, right? So
They
the,
control the budget, but do they control the?
no, so we go about negotiating with these things, right? And so what we are trying to do is now work with the hospitals to try and get them to use the biosimilars as opposed to the brand version. So where if they need X number of dollars to fund their operations and they're making it by having this large markup on these drugs, at least do the large markup on lower cost versions of those drugs as opposed to taking a large markup on an already expensive drug. That's what we're trying to do now, work with them to try and switch over that way.
And you have some sort of written agreements with the various hospitals in Vermont, or?
We have annual contracts that are negotiated between our provider contracting folks and the hospitals to kind of work out what the price would be. We don't have leverage where we get to dictate what the prices are to them, right? Like, people think of Blue Cross Blue Shield Vermont as this big payer, but in the end, we can't go without a hospital. We can't all of a sudden say like, oh, we're not going to have University of Vermont Medical Center in our system. We're not going to have Rutland, right? We have people in rural areas, and if all of a sudden we say like, North Country or some other place is not in the network, people are going to drive 40, 50 miles to a hospital, right? So we really can't play the game like in New York City, like where there's so many hospitals, like in a 3-block area, you can have like 8 hospitals. You can go ahead and say, well, this one's not going to be a network, this one will be, and negotiate the best rates possible. We don't really have that situation, right? So we have a possibility of these kind of things growing into existence. Yeah.
Actually, and has it grown? Have you seen?
Yes. I would have to go back and pull the exact data, but this isn't something that's new. This has been going on for a little while. It's just that as the ASP keeps on going up, that winds up becoming a continuation of the problem. Just give you
Is it also the case that, I was wondering, you said earlier part of what we passed was as biosimilars became available, that substituting them similar to our generic substitution law, as I understand it.
Yeah.
But how does that?
That works on the pharmacy benefit side.
Right. Why is that not applying to the hospitals?
I don't know. Like,
Maybe
I think
we could-
if we required the use of the biosimilar, so.
I mean, the issue, of course, is, that's a piece of this.
Yeah.
It's not the entirety of it.
Right.
And if you take the 340B financial gain the hospitals have, that is just going to shift the cost somewhere else. Right? It's not going to go away, at least not initially. And that's what the Green Care Board's job supposedly is to maintain adequate but not inappropriately great hospital budgets.
Right.
But if we took it seems to me that if you took 340, if you solve this problem by having 340B profits not available or directly to the consumers, the current cost of the hospital is simply going to be on the bottom line.
Right.
And shifted somewhere else because it doesn't.
At the end of the day,
automatically go away.
Right. At the end of the day, there's a overall healthcare infrastructure that has to be supported, right? And right now, it's being supported by large margins on drugs. If it's not supported through large margins on drugs, it's going to have to be supported some other way, right? And so, but at the same time, though, when we talk about drug prices, this is an issue that's going on, and
But it's also the case that while some individuals might say, well, why do you care? Why do we care? Why do I care personally about whether they use a biosimilar or a generic or a brand name drug if the out-of-pocket cost to me is the same, or in this case, if the system, if we're going to have to absorb it, well, it increases the cost of the entire healthcare system in Vermont.
Right.
So that's why it does matter.
exactly.
And so even if it doesn't eliminate this problem, and even if the issue gets shifted somewhere else, it is a partial, it's a small piece, but it's a piece of how to reduce the cost of the healthcare budget for the state of Vermont, rather than simply increasing the profit for the pharmacies, or for the manufacturers of the pharmaceuticals. At least that's...
The other point you can make is that if you have all the margin being made on basically drugs, lab work, and imaging, right? And then everything else is underfunded, you wind up with not a true sense of the cost of care of different approaches. So in some things where it might be one treatment could be medication, and another treatment could be a surgery and so forth, and we don't know the exact cost of care. We don't really know what is the best route for treating of that patient, right? And so, the best value for everybody, right? And so if we want to have this very inflated price here, just go over the cost, but then we're underfunding the surgeries, well, maybe it would be better understanding of the direction of the treatments if we have a better sense of what the costs are. So.
Could you put
Jennifer Carvey, Legislative Council. Just one small clarification on the biosimilar piece. I think the interchangeable biologics law that you passed, I think it was 2 years ago, I think, applies to a subcategory of biosimilars that are interchangeable with the reference product and not all biosimilars. And to my knowledge, there have, I'll look at those of you know, but I don't think the FDA has approved any biologics as interchangeable yet.
That is true. That is correct. And so that's part of it, right? So, so that's why we're, at the same time, we've seen clinical studies done that does show that there is the same clinical outcomes of the biosimilars that have been approved and the brand innovator versions, and that's why we're looking to take steps to go ahead and require the use of those biosimilars.
And that's why we did this in anticipation, but.
Right, so I think at this point, you could work with providers or prescribers on making a choice among biosimilars that is less expensive, but there wouldn't be the automatic substitution for a biological product the way there is on our prescription drug side.
This graph just basically shows the same thing about the percent of ASP, but it's just broken out between the different areas to show that, you know, it's not just in one area. This is something that occurs throughout the whole thing. Just give you a sense, this is one specific example. Ocrevus is a drug that treats multiple sclerosis. It's become rather popular. You have 2 injections, 1 injection every 6 months. It continues on and on. 84% of our utilization is occurring in outpatient hospitals. And if you look at, on average for 600 quantity, an outpatient hospital is paying $59,000, where in the physician's office it would be $38,000, or getting it through the pharmacy would be around $33,000. So you can see the price difference between the different channels that people can go ahead and get it through. And so these consultants that we were working with, we kind of worked out the idea, like, what if we could move patients rather than the outpatient setting to either home infusion, or if they could get it through the pharmacy and bring it to be administered, or in a physician's office instead, what would be the same? So we always looked for the place that was the greatest value from each of those. And when we went and did the full calculation, it would come to about $37 million in reduction in savings. So to give you a sense of the impact of the overall healthcare system just for Blue Cross Blue Shield Vermont members, that outside margin that's occurring at the hospitals versus the other locations, it's worth about $37.1 million to the overall healthcare system. So it's the best way we can go about quantifying what the impact is.
Wouldn't that just be shifting the, I mean, you addressed this earlier, I think. If the hospitals didn't have that 37 million, they would have to get 37 million from some other source.
That is correct.
If the budgets were,
so this is when we go in for negotiations with the hospitals and we tell them that we're going to go ahead and look to do this. Like, oh, well, okay, well then we need an increase other places to go ahead and do it. So it makes it a little bit tricky in that sense. I mean, ultimately you go back to the point Chairman Lipper was making about the overall cost of the hospital healthcare infrastructure has to be covered in costs in one way. It's just that the way it's a large chunk is being covered right now is through drugs, especially drugs on the medical side. Any questions on this side or anything else around the pharmacy benefit?
Maybe I'll say out loud what I was just saying, is that, and that's why we have tried to have the Green Mountain Care Board have overall view authority rather than simply having everything just be, well, let's push the balloon here and then it comes somewhere else. Because if we solve these problems and if there's not an entity to actually look at the overall cost issue, we haven't really solved the problem. Whether we believe that the Green Mountain Care Board is functioning in an optimum manner, or if there are other things they could do, or hospitals could reduce their budgets further. I mean, my view is that we need to understand each of these dynamics, but we need to not get confused by the fact that if we solve the $37 million problem here, that doesn't require some other issue. Our purview is the healthcare system of Vermont, and not simply one aspect.
I agree.
But we need to keep moving at every point where we can have an impact.
One, to make this aware, because people often ask the question of why are drug prices so high?
Yes.
Right. And this is the point. I'm trying to make that point of that, you know, there's a reason why these things are priced the way they are. It doesn't necessarily have anything to do with the, you know, on the medical side, it's not always about the manufacturer, right? There's these other factors in place too. It makes it tricky. That's
Great.
it. So any other questions? All right.
Thank you very much.
Welcome. Thank you.
Appreciate it.
So I thought I would just go over some of the prescription drug costs and trends that we've been seeing over the last few years. You probably know Medicaid is a completely different animal from a commercial payer, and I'll try to point out some of those differences as we go through the data. So this is just a snapshot of our drug spend over the last 3 years. And I'm going to bring your eyes down to the bottom chart, which is Medicaid. The top chart includes our VFARM program. And because that's we're the secondary payer in VFARM, it sometimes skews our numbers. So if you look at the Medicaid, that would be a more accurate representation of trends. So I did a 3-year trend because we always have Medicaid with the huge amount of money that comes through the rebate program. It does cause fluctuations in our program. So I thought it would be more accurate to give you a 3-year overview. So in the dark blue, where it says 3-year trend, those are the numbers that I want to point out. So first of all, I didn't actually total claims for some reason, but we actually did see a decline in the number of claims that we processed between 17 and 19 of about 3.75%. We saw an increase, however, in the total amount we paid pharmacies. So this is gross spend. It's what we actually pay the pharmacies. So we saw a 2.5% growth in payments to pharmacies. This last fiscal year, it was about $193 million total, and that's for about 160,000 people, roughly. If you look at our cost per claim, somewhat similar to Brian's data, we did see an overall gross increase in cost per claim of about 6.5%. Now that is over a period of a couple of years, so I think it's actually lower than what Brian showed us. But we are seeing increases in the cost per claim. And then when we look at the net cost per claim, so the net cost for Medicaid is whatever we pay the pharmacies minus whatever we collect in a rebate. So all of the rebate offsets are incorporated into the net number. And so when we do that, we've seen an overall 3-year trend of 2.2%, which is a very modest increase. And that's largely driven by the Medicaid rebate program. So our net...
So kind of back to Brian's, we had the medical versus pharmacy, but for Medicaid, it's all pharmacy?
So you're just looking at pharmacy right now, although I'm happy to bring back medical at a future time as well, because there's a lot of parallel there as well.
Right.
So net amount paid, there was an overall decrease of 1.7%. Now, you can see that the number of claims went down, and the net paid amount went down. And that's largely because we have had shifts in eligibility. So for the last 3 years, our eligibility has declined about somewhere between 7 and 8%. So a lot of this decrease is driven simply by the number of members we have enrolled. So gross and net PMPM. Our gross PMPM is actually quite similar to Blue Cross. We're up about $100 PMPM for 2019. When you take into consideration the rebate program, you can see over the last 3 years we are seeing gradual increases, but our net PMPM is about $36. And then this chart just shows that, over a longer period of time. So here we're looking at 7 years, 8 years. And the blue is the pharmacy gross, the pharmacy payments, the gross spend. And then the orange line is the drug rebate collection. So you can see they track pretty closely. They tie together quite nicely. So yes, spend has gone up, although it's leveling off now because we've had shifts in eligibility. But the rebate collection is also going up pretty close to aligned. And so when you look at the bottom chart, that's really just those two numbers subtracted from one another. And so the bottom line is just our net expenditures when we consider all of the rebate. And it kind of peaked in 2015, which is exactly when our eligibility peaked. And then you've seen it kind of come down and stabilize. There is going to always be a little bit of variability year to year. But overall, if you look at the last 8 years, we've done quite well in managing net spend for Medicaid.
Can you say something more about the rebates, because they're significant, and what it is and how we go about
Sure.
ranging for that? I don't know quite what word to use without
Sure.
having a judgment. And then maybe how that relates to non-Medicaid
Yeah.
expenditure for the same.
I'm going to flip to a little bit later slide, and then I'll come back to.
Is that, or do you want to come to it later? And you can,
No, it's fine. I can flip back and forth. So there's essentially there are 3 different types of rebate programs that we manage, but 2 of them are directly tied to the Medicaid drug spend. One of those is the federal rebate program, and that was established in 1990. It was over 90. It actually went into effect in 1991. And that required manufacturers to pay a % of the average manufacturer price of a drug. That's just the price that a manufacturer sells to a wholesaler. They're required to pay a fixed % for brand drugs and a different % for generic drugs. It's higher for brand drugs. And really the saving grace, I would say, of the federal rebate program is that the over 90 legislation imposed a consumer price index factor into that rebate. So if a drug's price exceeds the consumer price index for that year, then essentially Medicaid is getting back a large portion of that increase in the form of a rebate. So that has had a really moderating effect, because a lot of the really high price increases that have impacted gross prices, we've seen comparable increases in the rebate payments for Medicaid. So that does have a big effect on moderating prices. So this is a mandatory
for Medicaid.
For Medicaid.
Yeah,
Yeah,
only for
strictly
Medicaid.
only for Medicaid. I will say that the 340B drug discount program is actually based on the same formula with a few differences, but essentially it points to the same statute. So they're similar in that sense. So for Medicaid, there's this required federal rebate. And then in addition to that, Vermont participates in the Sovereign States Drug Consortium. And that is the only state-owned, state-run rebate pool or a consortium. We have now 12 member states. Vermont was one of the founding members of that consortium with Maine and West Virginia, and we now have 12 states participating in that rebate pool. And what that pool does is we go out representing all 12 states to manufacturers, and we negotiate additional rebates on top of the federal rebate. And that's been very successful as well. And so we are collecting an additional somewhere between $10 and $12 million a year as a result of those additional negotiations. This slide just gives you the grand total. So on 2019, for example, we spent $193 million gross, but we collected almost $127 million for all those rebate programs back to Medicaid.
And the rebate is tied to what is the highest price that the rebate is being rebated from? Is it because we hear different terms. Is it wholesale? I'm not sure which term to use to describe it.
You mean what is the magnitude of the rebate?
Well,
or?
not just the magnitude, but the fixed, the point, the reference point.
Well, the reference point is the average manufacturer price, and
That's
it's
what I'm looking for, yeah.
and it's 23.1% of AMP plus the CPI penalty, and then there's other factors. I mean, it's quite a complicated formula.
But I think without knowing the complications of the formula, I think it's significant to understand that the rebate, that the Medicaid program benefits from this is substantial.
Well, I'll give you some context around that.
So both the savings from the federal requirement and then the state's participation in the state rebate.
Right.
On top of that is actually.
It is substantial, yes. And the numbers show you how substantial it really is. But for any given drug, it can be anywhere from, for a brand new drug where there hasn't been any inflation factor, it's sort of the minimum rebate, right? That's roughly 23%. But for drugs that have been on the market for a long time, depending on price inflation and many other factors, some drugs can be extremely inexpensive or free for Medicaid. So it's anywhere from 20 to 100% when you start looking at individual drugs, and that's highly variable. But overall, our average is about 64% of our entire drug spend comes back to us in the form of a rebate.
The flip side of that is, 36% is being paid compared to the 100% that's being held out as the reference point. Is that fair to say?
Yeah.
If that's the reverse of the way I did my math, it's a quick thing.
That's right.
So, and that type of discounting is not broadly available throughout the healthcare system.
Right.
So again, to just notice the magnitude of that. I mean, we also spend enormous state dollars on Medicaid and federal dollars, but nevertheless, in this arena, there's a huge savings.
Right. Okay, let me go back to, so I did want to just point out where our money is going. The drugs on this list represent about half of our gross spend, so it's a pretty substantial portion. The difference, again, between us and a commercial payer is our patient population is dramatically different. We insure, this comes into play with specialty drugs as well, but many of our members are children, roughly about 35% of our members are children. About 90% of our members are under the age of 65, so we insure very few people that are over the age of 65. So that has a real impact on the types of drugs that you see a Medicaid program use. And so substance use treatments, of course, always have tracked very high for Medicaid. This chart reflects the change between 2018 and 2019. And so what is the change in the total amount paid as well as the number of claims? So this just tells us that overall substance use treatments, use of MAT for substance use is increasing, and that's a good trend. We do want to see more people in treatment, and despite our eligibility numbers dropping, these numbers are going up. So that's a positive. In terms of other drugs, we use a lot of insulin. Hepatitis treatment is very high as well. Those agents are very expensive, so they tend to hit our top 10 list pretty quickly. You can see that there aren't many claims, so under 900 claims, but we're spending $12 million on those 900 claims. So that's a huge impact. Because we insure so many children, we see a lot of drugs used for ADHD, for attention deficit. disorder. So if you look at the stimulants and then further down the chart, you'll see amphetamines for ADHD. That's about $20 million just for children being treated for ADHD. So that's had a significant impact.
Do you have any state-to-state comparisons? That's a tremendous prescribing for children for ADHD in a state this size. And I remember reading in the past, some various studies that it's looking at.
I do.
Some feel
Yes,
like
I
it's
do.
overprescribed
We can get back to
ADHD.
you with some of that. Yep.
I'd be very interested in that. That's
Sure. Cystic fibrosis is also having a big impact. So we have seen almost a 15.5% increase in gross amount paid for that, and a 9% increase in claims. There have been some new agents that have hit the market for CF. Some of them are very good agents and help keep patients out of the hospital, so that's a real positive. But they're very expensive, so we're spending about $5.5 million, and that's only for about 560 claims. And then HIV, another $5.5 million roughly on HIV medication. The cost of these drugs is going up, so we have had almost a 4% increase in what we're paying, but a decrease in the amount, the number of claims, and that again is primarily eligibility driven. It's not that we're really treating less disease. So it just gives you a good snapshot of where the spend is going.
I have a question.
Yeah.
This may have nothing to do with it, or I'm reading things wrong, but insulin, it's gone down, the claims count, and would that have anything to do with people just not filling their prescriptions?
No, it's more likely just eligibility has dropped about that amount. Yep.
Thank you.
Yep.
No. Hold on, I think there was a question.
Yeah.
Well, I wanted to just note, and I'm not sure, I think it's reflected here in Medicaid as well, but there was, I think, within the budget proposal, there's an HIV proposal from Eva around changing some language in the statute about substituting some medications around HIV. Are you familiar with that?
Yes.
Do you want to explain what that is and what the consequences would be, or the
Sure.
outcome of that would be?
Sure.
Just 'cause we're going to be talking budget in a few days, but I think since we're here, maybe
Yep.
talking about it would be useful.
Sure. So the best practices and cost control statute, which happened around 2001, that's the statute which I was going to mention in a little later slide, but that's the statute that allows us to create a preferred drug list, which is like a formulary, a drug formulary, and our preferred drug list is probably the most important tool that we have to control cost. So I've shown you all the rebate numbers and how significant that is, but the reason why that's so significant is because we do a pretty good job of driving utilization to the drugs that have the lowest net cost for Medicaid, and that's the purpose of the preferred drug list. I mean, and I'm not saying there's a lot of clinical that goes into the PDL as well, but that is a very important tool for us to control cost. The cost control, the best practices and cost control language, when it was passed, it was just the beginning of our PDL, and there was a lot of concern about patients being impacted. Would they still be able to get the medicine they were taking? And so I wasn't here back then, but I know there was a lot of discussion about this at the time. And so one of the only class of drugs that we were prohibited from managing on our preferred drug list was HIV. And that's because there was 20 years ago, there was a great deal of concern about patients not being able to access their HIV medication. We are able to manage every other class, including cancer, including antipsychotics, all the mental health drugs, and we've done so very successfully without having a negative impact to patient care for the last 20 years. There is a large amount of money that we are leaving on the table with HIV because we have not been able to place them on our preferred drug list. And of course, manufacturers, the reason they give us these additional negotiated rebates is because in exchange for those rebates, they want more market share, better placement on a preferred drug list, to be in preferred status, for example, or maybe not to have a PA applied to their drug. So these are the negotiations that go on during that 7 states effort. But we've not been able to negotiate any additional rebates for these medications because we can't manage, we can't list them on the list. We can't put them on the list. And so.
By virtue of statute.
Yes, that's
in the
correct.
statute, yeah.
That's right. Yes, the statute says that we cannot manage them any more tightly or any more, we can't put any limits or anything on those drugs any more so than the VMAP program, so the Ryan White program that the Department of Health manages. And they have very few, if any, restrictions on that program, so that's been the limiting factor.
So we'll come back to this issue as a committee because it's a budget issue. I think it's over some, I remember 1.7 million or something estimated savings.
Yeah.
But it's been historically a highly sensitive area.
Sure.
For reasons that you've stated and concerns that Vermonters impacted by HIV/AIDS might not get the medications they need as a result of this, if we were to allow the change. But I just wanted to note it, we'll come back to it, and it'll have to be a policy decision.
Okay, great. So specialty drugs, we do look a lot different than Blue Cross, and that's again because of our patient mix primarily. So over the last 3 years, we are seeing growth in specialty spend. So we started out with about 20%, we're up in excess of 25%, but we're not at 55%. So that is a difference with Medicaid. The types of specialty drugs we see, we do see a lot of the drugs that are used for the inflammatory conditions like rheumatoid arthritis or ulcerative colitis, those types of diseases. But then we see cystic fibrosis, for example, in children, not as much in the area of cancer drugs, just because the age of our population is young, and we do use some, of course, but we're not going to see as much use of cancer drugs in our population. That said, we are spending $50 million a year on specialty drugs, so it's certainly not insignificant. It's a huge portion of our spend. I thought this was important to see why everyone's so focused on specialty, whether it's pharmacy or medical spend, and that's because the average cost of a specialty drug prescription is vastly different than a non-specialty prescription. So we spend on average over $7,000 per prescription for a specialty drug, but if we look at all claims, now the all claims include specialty, so I didn't actually take those out. So if we did take those out, this would even be a lower number. But our average cost per prescription is about $114. So that is why specialty has, even though we see very few prescriptions for them, they do have a huge impact on the budget. So I already went over the rebate slide.
Can I just ask a quick question? Are there any rebates within specialty drugs?
Yes, definitely.
Okay.
Yeah. So I did talk a little bit about our preferred drug list. As I said, our most important tool for assuring that we are using clinically appropriate drugs that have the lowest net cost to Medicaid. And then the federal rebate program, I touched on that. The supplemental rebate, I touched on that. So these are all strategies that we use to control costs. And then I want to just briefly touch on the 340B program. The AAC, by the way, is actual acquisition cost. So the difference between Medicaid and a commercial payer like Blue Cross with 340B is that the federal statute requires 340B entities to pass their acquisition cost along to Medicaid. So, and that's because we cannot get a rebate on a 340B drug. That's prohibited. That's called double dipping. So because the 340B drug discount program is similar to the rebate program, essentially, we can either get the 340B discount, or if it's a non-340B drug, then we can collect the rebate, but not both. So that's another important distinction, because even though the hospitals participate in the 340B program, they can choose whether or not they want to enroll with Medicaid's 340B program. And if they do, they must pass along their acquisition cost. On the pharmacy side, for example, Community Health Pharmacy, they did participate with us for a long time, but in 2019, in the second quarter of 2019, they disenrolled from the Medicaid 340B program. So we call that carving out. So they don't have to participate with us, but if they do, they have to pass along their acquisition cost. In the pharmacy world, we pay them 340B acquisition cost plus our usual dispensing fee, which is $11.13 for most drugs. It's a little higher for specialty drugs. So that's yeah.
I'm a little lost. So what's actual acquisition cost?
So in the 340B world, that's whatever the entity paid for that drug.
Whatever the hospital paid for the drug.
Or the
That's
FQHC.
correct.
Or the FQHC pharmacy.
Yes.
Okay.
So they don't get to keep the markup,
Right.
in other words, with Medicaid.
If they join the Medicaid 340B program.
That's right.
I'm just trying to think through what the advantages and disadvantages are to choosing to participate or not participate. I mean, ultimately, what are the advantages? Because if they don't participate, they get to keep.
Well, if they don't participate, they cannot use 340B inventory for Medicaid. So they would just be paying their regular, they would be purchasing the drugs through their normal channels, their non-340B channels. So they'd be paying more for the drug, but they would be getting reimbursed more for the drug.
Right. Of course, there's not much more. The difference is, how does that compare?
What they can't do is cherry pick, so they're either in or they're out, but they can't say, oh, this drug this way and that drug that way. Yeah.
And can they come in and out of the 340B program with Medicaid?
Yeah, whenever they want. I mean, they can make that selection every quarter
I was just saying,
with
you
HRSA.
mentioned they did it partway through the year. So they
Yep.
do it in a quarter.
That's right. For Medicaid, it's a fair amount of administrative work for us to manage that program. That's just another different pricing methodology in both the pharmacy benefit and the medical benefit. And then we also have a pricing methodology for generics that's called a MAC or a SMAC. It's a maximum allowable cost. Yep.
That's what I thought.
There are a lot of those terms in pharmacy. So the SMAC is the state MAC, and we apply a set price for a collection of generics. So for any given drug strength dosage form, we set generally something midway. So if there are 10 different manufacturers that make a drug, there's going to be a lot of variability in what those manufacturers are selling that generic drug for. So if it's $2, the lowest price is $2 and the highest price is $15, we're going to strike a happy medium there, and that's just to encourage pharmacies to be smart purchasers of generic drugs. So the lower they can buy those drugs for, the better off they will be and the better off we will be. So it's a good methodology for setting generic prices. And then on generics and brand drugs, we implemented in 2017 a new pricing methodology. I didn't put it on here, but it's called NADAC. That's the National Average Drug Acquisition Cost, and that's a new benchmark, different than AWP or WAC. Sorry, but it's a different methodology that gets us a little closer to what a pharmacy actually pays for a drug. So it's intended to be a more accurate benchmark of pharmacy acquisition cost. So when we made that change in 2017, we moved away from average wholesale price, which everyone knows ain't what's paid, and we went to NADAC. At the same time we did that, we changed our dispensing fee, and this was all states did this. It wasn't just Vermont. It was something that CMS required all states to do. And so at that time, CMS required the states to do dispensing fee surveys to adjust the dispensing fee to pay more closely to what it actually costs the pharmacy to dispense and counsel and all of the things that they have to do on their end. So we made that adjustment a couple of years ago. The last thing I wanted to just touch on was this relatively new phenomenon called value-based agreements. And essentially it's you can look at it sort of like a supplemental rebate. So it's sort of like those supplemental rebates, but it's often based on the value or outcome that drug produced. So someone earlier was asking about outcomes. Is the drug really working? Is the patient improving, and all of that? So these agreements are based on, they're all different configurations of these agreements. I'll just give you one example where if a drug is not effective, the manufacturer will rebate the cost of that drug, or 8% of the cost of that drug. Or if the patient has a relapse within 5 years, they will reimburse a certain portion of that drug through a supplemental rebate. So they're fairly early in development, and we are watching how they're unfolding. I mean, it does present a potential opportunity for us. So right now, there's only a few of these in place with Medicaid programs around the country, and we're just kind of waiting to see how they're working for some other states that are doing some models on behalf of the consortium. So we'll continue to monitor that, but we are going to be getting approval from CMS to be able to implement these, so that way, if we see one that looks attractive and beneficial to us, then we will be able to take advantage of that. So
these are not arrangements that have to be negotiated state by state.
Yeah. Well, we will be able to do them through the consortium.
But through the consortium, but I mean, it's like, is each state having to create parameters for what the value-based? I mean, I would think.
Yeah. I mean, there are a couple of other. There's one other company that has rebate pools that are doing this kind of arrangement as well. But it is largely up to the states to determine and the manufacturer, of course, to determine how they're structured, how they're going to be measured, and the data analysis can be very extensive because you're looking at medical data, outcomes, specific patient data. So it's much different than a traditional rebate where you're just looking at drug claims. There's much, much more to look at in a value-based agreement. So more to come on those. And I just wanted to touch on, I have mentioned that we've done a pretty good job of managing costs, but I don't want, although we have seen some modest increases, But I never get too comfortable about that because there are so many new, very expensive drugs that have reached the market or are in the pipeline. So I'm always very cautious about, projecting future growth because the impact of these drugs can be really significant. So I just put a couple of examples out here. There's a new drug for cystic fibrosis. It's called Trikafta. It's a triple therapy, and it is a drug that can be applied to almost the entire CF population, can be useful and successful in treating CF. It's at a cost of about $300,000 per patient per year, and it's for the lifetime of the patient. So right now we're spending, this is $4 million just on these types of drugs, which are called CAFTR drugs, but altogether we spend $5.5 million on all CF drugs. So we'll see how this drug, what kind of impact it has, but we are expecting that this drug will have a significant impact because it is going to be applicable to almost our entire CF population. There's a new drug out for sickle cell disease. We don't have a lot of sickle cell in Vermont, but we do have an estimated 5 patients that might be eligible for using this new drug, sickle cell is a very painful disease. They get pain crises that require very high doses of opiates just to control the intense pain from this condition. So this drug is targeted on those pain crises. Roughly $110,000, $115,000 a year for a monthly infusion. So we're looking at potentially about $500,000 on that drug. And then a couple of, the last 2 are oral drugs. One is for tardive dyskinesia. This is a condition that people get when they're on psychotherapeutic, antipsychotics in particular, movement disorders, facial and other movement disorders. It's about $60,000 a year for this drug. And then Emflaza has been around on the market for several years. It's used to treat Duchenne muscular dystrophy. It's an interesting drug because the patent's been around for over 50 years. So this is not a new drug, if you will, by any stretch of the imagination, but it's costing $80,000 a year to treat patients. And then I just want to touch on some of the new gene therapies, which are really ultra high cost drugs. We have not had utilization of any of these gene therapies thus far, but we will. There's no doubt that we will eventually. Some are used for lymphomas. One is used for blindness, and Zolgensma, which you may have heard in the news. It's the most expensive drug in the world. It's $2.1 million for a treatment, and it treats, I'm blanking. Thank you. SMA, spinal muscular disease, which is a very devastating disease that causes early death. It's really devastating. And so this drug shows a lot of promise. It's only for use in children under 2 years of age. You need to be treated basically before you lose your muscle tissue and strength. And if you do that, then it's so far very promising for this awful disease. So, these price tags are impactful, but when you talk about outcomes, it's also a consideration that you have to think about. This child is going to live much longer, they're going to live a much more productive life, and probably not need as much support as they would have otherwise. These children are usually on respirators. They can't breathe because their muscles don't work. So there's a lot of considerations, but I just wanted to point out that these are huge. This is huge amount of money for treatment of these rare diseases. I think the most important thing on this slide is that there's over 300 of these products in the pipeline. So many of them are rare diseases, not all of them are rare diseases, but this is where we are going to see growth over the next 5 to 10 years. And it's going to be a lot of money. So. I do want to just comment briefly on the physician-administered drugs, since Brian's presentation very importantly pointed out the medical benefit. We also process a lot of drugs through our medical benefit. Our fee schedules are different. I did want to correct myself. We do pay 100% of ASP, not 97%. That change was made in 2019. I forgot about that. We have been for quite a long time now on our preferred drug list managing both. In other words, we apply the same criteria to drugs, whether they come through pharmacy or whether they come through the medical benefit. We apply the same criteria, and we do try always to manage to the lowest net cost. There's always room for improvement and managing more drugs on the preferred drug list, and that's an ongoing effort. But this is an area that there is definitely increased focus in this area for us as well. Just because with all the specialty drugs that are coming in the market, and the gene therapies for that matter, they're all administered hospital outpatient. Or many of them are administered hospital outpatient. Some of the gene therapies are inpatient as well. So we can't ignore that aspect of growth as time goes on. We are going to see more growth in that area.
Any questions?
Thank you. I've said this when we talked about some of these high-cost specialty drugs, et cetera. And I feel compelled to just always say, it could be any one of us, or a family member, our child, or one member of our family who suddenly is in need of something, and there's something along these lines that's extraordinarily expensive. And I don't attribute this to you at all, as I've said before, or Brian or anyone else. I think we just need to keep in our minds that as we look at these very high costs and hopefully very effective drugs, that we're not in any way trying to point the finger or target any individual Vermonter or family who may need to access some of these drugs. It's our job to look at the broad issues of healthcare policy, and it's not a matter of saying, well, if only we didn't have to take care of that person or this group of people, et cetera. So I think it's always a cautionary thing for us to keep in our minds as we look at these and some other healthcare issues as well. Yes, thank you. We did not ask you to prepare for this, but I wanted to at least ask, and if you're not prepared to answer it today, ask you at another time to answer, to make comment, both to Brian and as well as Nancy. And again, I greatly appreciate both your flexibility in coming back today when we couldn't get to you the other day, but also for the depth of information you're able to provide. The question I would have is, or in part, is based on everything that you see, are there any policy recommendations that you would bring to us as the House Healthcare Committee in terms of policy, statutory changes, or other policy changes that we might have the ability to impact that are outside the control of you as someone working with Medicaid or you as working with Blue Cross Blue Shield? I'd be very open and interested to have you comment.
Most of my focus is, I feel that these problems that I raise are federal issues, and they really get into intellectual property rights law, and it feels how helpless to be able to do something on a state level, but ultimately that's really where the crux of it, either having some sort of federal laws that involve the setting of prices on the federal level, or at least correcting the intellectual property right laws so that it allows a regular margin to be made and still have an incentive to come out with these new medications, but not to the point of, triple to quadruple the margins that the rest of the industry is making, right? Like, that's where there needs to be a correction made. And I wish I could say that there is a salve from the state level, but off the top of my head, it's more like nibbling around the edges as opposed to like really addressing the root cause of those issues.
I would agree with that.
I think that's helpful, however, to even have that perspective articulated as we, of course, can impact what's possible at the state level and still have some ideas. But it's very frustrating to not be able to have the kind of impact that we could have at the national level.
I think the biggest policy issue right now with us would be the HIV class. We've at least put that on the table this time. So the biggest thing for us is just not having our hands tied to be able to negotiate and not pay more for drugs than we should be paying for drugs. That's the biggest thing for us.
So as we look at some other proposals that have been put on the table, that I think some may have to do with PBMs and others have to do with the Prescription Drug Affordability Board, which Maryland has started to look at, which are state-based, attempts at state-based solutions, or maybe not solutions, but attempts to try to moderate some of the impact. I would welcome each of you or others in your shop. We'll be asking for comments on that as well.
Thank you.
Thank you.
Thank you very much.
If you can just remind everyone where this came about, that'd be great.
If I can. So for the record, Mari Cordes, representative from Lincoln, and I'm speaking to you as your colleague, not as an expert on PBMs, pharmacy benefit managers, but I did, we had some discussion about our work as a committee to try to control the cost of prescription drugs. And so I did a little research over the weekend so we can talk about what PBMs are very briefly, and why NASHP has the National Academy for State Health Policy. They have a whole section that I encourage you to look at on prescription drug pricing with some great presentations. So I'm going to talk about what areas we might be able to address with PBMs as part of our work to control prescription drug costs. And you'll see I have 2 things posted on our website. The one I'm going to pull up now is the role of a pharmacy benefit manager. The second one is just something for you to look at as a possible another step, not just working on PBMs. So the pharmacy benefit managers are administrative organizations that are administrators of pharmacy benefits. And they contract with health plans to administer those benefits. And they do a number of things. They can set up a health pharmacy network, which can include the preferred pharmacies, and they design formularies. The plans list of covered prescription drugs, and usually that does include the different tiers. And I put a picture of my own benefits here, so you can see an image of the tiers. The specific medications aren't listed here, but I can tell you that tier 3, if you look at the co-pays under tier 3, UVM Health Network outpatient pharmacies. So I, as an employee, if I go to a UVM Health Network Pharmacy, I have, if I use Tier 1, which I believe is the medications that were spoken of earlier, like the statins, atorvastatin, furosemide, or Lasix, those would be a zero cost to me. And if I buy, if I need a steroid inhaler, then it'll be $90. So Tier 3 is more expensive. And when we talk about utilization, the goal is to try to drive utilization towards the lesser expensive meds. The pharmacy benefit managers also pay pharmacy claims, which then the health plan reimburses. And I'm going to go back to this slide just to get a sense of how complicated it can be, because there are multiple entities in the process. There's the manufacturers, the wholesalers, pharmacy, the benefit managers, the health plans, the employers, and then the people who are receiving the medications. And while I was doing a research, I don't know if anybody has ever seen this website, but I'd be curious to know where it came from. We do currently have a law now, the 2018 law, that addresses that. So just for fun, I added myself to their email list to see if anyone would get back to me. Anyone know who they are? Have you seen it before?
Are they banned by state law?
Yes, we banned
Yes,
it. We
the
banned it
gag
last year.
order is banned, and I'm going to go into that
And there's now,
shortly.
I think there's a federal, there was a executive order rule.
So the pharmacy benefit managers negotiate drug prices, and because because it's such a massive industry, there's a lot of leveraging power, especially, so this works better for larger plans. But the negotiations are confidential. And the rebates are based on the volume of drugs dispensed to the PBM's health plan enrollees. So some of the manufacturer rebates do go to lower the cost in the health plan, but because it's confidential, we don't know how much. And one of the issues is that because there are only a few PBMs nationally, the three largest are CVS Caremark, Express Scripts, and Optum Rx control 72% of the market. So the pharmacy benefit managers, most of them absorb or keep those rebates that they obtain in negotiation with the manufacturers. There's one PBM called Navitus, who is the PBM for, I didn't put a slide here, for UVM Health, either Health Network or just my hospital. And they use administrative fees. So they claim, Navitus claims that they're more transparent. They don't pocket the rebates. They make sure that that money gets forwarded towards the people buying the prescriptions. People can actually audit their claims to make sure that the price Navitus got from manufacturers, they can follow the chain from that price to payments to pharmacists and what they're paying. Other comments have noted that Navitus is better than the other options for PBMs, but they still are a PBM and they get in the way of patient care. I'm just going to skip some of this and get to, so PBMs may have an incentive to prioritize high-priced drugs over drugs that are more cost-effective. And this has been cited explain reports of cases in which tiering or other utilization practices have been used to steer people towards those medications. So again, transparency is a major issue right now. So NASHP had created some model legislation, and it's designed to address potential conflicts of interest. There are some PBMs who are directly related to drug manufacturers or to pharmacies, so they have an interest in working only with those. As I mentioned, the lack of transparency and the incentive to go with higher cost medications in a formulary. So the Model Act encourages administrative fee-only compensation, like NABALIS, and would guarantee 100% pass-through of rebates to the states. So the money saved in negotiation, especially with large contracts, would go to the states. It wouldn't be caught in between the PBMs and the manufacturers, or it wouldn't go directly to the PBMs. Ensure price transparency and member cost-sharing protections. It also would recommend state licensure, and there are many states that do license PBMs. When I looked at Vermont, we are required to register them, but we don't license them. So that may be something, or not, maybe something that we want to look at. There is some oversight required with the registration. I think it's a reporting requirement. But again, it's not licensure. Fiduciary responsibility. The Model Act requires PBMs to have fiduciary duty to its health plan clients. And here's something you'll see in the slide of the 2018 Act 193 in Vermont. One of the biggest issues is that PBM contract provisions across the country limit a pharmacist's ability to notify customers about the least expensive ways. So they're not allowed to tell customers if there's a lesser expensive alternative. So some states already have these gag clause bans in legislature, and our 2018 Act did that. Patient out-of-pocket costs prevents a health plan from setting patient copays or coinsurance at a higher level than the actual cost of the drug to the health plan or its PBM. Address the conflict of interest issue, which I talked about. Rebate transparency, which I talked about as well. And some PBM contracts limit which drug wholesaler or distributors the pharmacy can buy from. Those PBM-specified distributors may serve the PBM's financial interests more than the pharmacy. So the Model Act would prohibit that. And then the last one is what I mentioned earlier, this other presentation or discussion about a statewide purchasing pool for prescription drugs. So they include that in their suggestions for how to address the negative impacts of PBMs.
Is that a multi-state purchasing pool, or have it looked at this?
I think it's state by state, but I don't know if there are other states that looking around.
I know NASHP and Peter Sterling from Nash's office on it. We kind of hashed it. They're talking about the statewide, just not multi-state. It would be using the state employees benefit and allowing people to buy into that. The thing that's the difference here is, and actually agrees with this, that we have a unique situation where Blue Cross Blue Shield of Vermont, we have 70% market share, so we're basically are that pool that we're trying to put together. So we have 140,000 members, where the state only has 23,000. So trying to put that together is not going to create the same volume. So it didn't seem as if it was going to be an option. And also, if I could just, a lot of the issues, I agree that those are issues that were just being pointed out. We contractually make sure that those aren't happening in our agreement. So when we're doing our, with the PBM, so like 100% of the rebates have to be going to us. In addition to that, 100% of the administrative fees they receive from manufacturers, basically any revenue they receive from manufacturer has to come to us. We also have to have full audit rights and so forth. So we put in that they can't have a gag clause in their contracts with the pharmacies and so forth. So a lot of those things, they do occur when they're often when PBM's contracting with a smaller employer, and it's not as, it doesn't sound like as sophisticated of a buyer. Like, this is what we do all the time. This is all my job for the last 20 years to do, right? So you wind up learning the games of playing to try and put things into the contract. So, but those things could occur with somebody that's not doing that, focusing on all the time. So they can occur. It's just a matter of how you're addressing in your contracts.
Thanks. I have a question for you. I tried to find in the state website what PBMs were registered in Vermont, and I couldn't get to it. Do you know how many?
I don't know. I know.
I think it's the AGO's, it's the AGO website.
I think that's where I was. I could get to a place where I could register as a PBM, but I couldn't get to a list that showed me who was registered.
If I could guess, almost anyone that is in business is going to have to, because their members are going to travel, right? And so people always are everywhere. You need a network with every single state in it. So my guess is that anyone that's doing business as a PBM is going to want to have a register in the state. I think it's probably an assumption, but I'd be surprised if they're not.
Well, I've heard the issue raised previously, and I can't remember what all the implications were of licensing versus registering. And I know that some colleagues have talked about the move to license PBMs rather than just register PBMs. I'm interested in understanding what that might involve and what the pluses or minuses of that might be at some point. All right.
Would we be better off to purchase some sort of purchasing agreement with Canada?
We're going to talk about that. I have one more quick question.
But just to say, Brian, that is being pursued. That's something this committee authorized along with.
So we're going to look at this and look at that and pick one?
Well, we need to decide where the best bang for the buck is, if you will, or bang for the policy decisions.
Does Blue Cross Blue Shield of Vermont, do you use PBMs, or are you a PBM?
No, we contract with Express Scripts for all of our commercial business, so it's Exchange and all the large group. And then for the Medicare business, that's with CVS Care.
Okay.
So we contract with two of them.
Okay.
And we did include Navitus in our last RFP, and their pricing wasn't as strong as the others, so they didn't make it that far. So we have considered that.
Thank you. Thanks, Mark.